Welcome to the Wow MD podcast, where in each episode you will get in 30 minutes or less valuable pearls about holistic wellness, anti-aging, hormone therapies, beauty trends, and other facts you should know about our medical healthcare system and your health that no one is telling you. My name is Dr. Mirala Chernayanu. I am a conventional board-certified OBGYN physician who, after the loss of my father due to a careless and uncaring medical team, decided to retrain and seek certification in anti-aging and restorative therapies. What I know, I am happy to share with you. As I promised, in this episode, I'm going to address painful sex related to endometriosis. So let me start by saying a few words about endometriosis. What is endometriosis? First of all, endometriosis does not affect just young women. It can impair and disable women even after menopause. So endometriosis is when the tissue that lines the uterine cavity, allowing a woman to carry a pregnancy to term, this tissue called endometrium, again, a very unique type of tissue, only exists in the uterine cavity. This tissue, for some reasons we do not clearly understand, it grows outside the uterus, on the ovaries or the tubes, on the surface of the uterus, or the ligaments at the bottom of the uterus, and other places. This specific type of tissue, the endometrium, suffers very specific changes under the influence of our hormones every month. It grows to allow thickening for implantation, and then it breaks down and bleeds every month, regardless of where it is located. So if it's in your ovary, it will bleed inside the ovary, creating a blood-filled cyst called endometrioma. By the way, that hurts when it forms, and it hurts while it's there. When it's on the surface of the uterus, the tubes, the peritoneum, the little fine tissue that covers all our feminine organs, it bleeds each period. But the blood lingers wherever it happens, and it stays trapped. It has no place to go, like the uterine hemorrhage that happens when we shed the lining. It goes through the cervix into the vagina to be captured by a tampon or a pad. This just lingers outside the area inside the pelvis, right? Outside the area that bleeds inside the pelvis. So this will cause inflammation and scarring around the feminine organs, manifesting with pain during and in between periods, painful bowel movements, infertility, and painful sex. The research for endometriosis has been underfunded since 2016 or earlier because apparently this condition is not fatal. So if it's not fatal, there's no interest in spending money to find out how to treat it best. It is highly debilitating. But again, if you're not at risk of dying, the government entities that are distributing funds for research do not consider a life of pain for women a priority. Now, let's talk statistics. Apparently, endometriosis is a very common health condition because it's estimated at least 11 to possibly 15% of women have endometriosis, which can come up to more than 6.5 million women in the United States. Globally, worldwide, endometriosis affects about 10% of women, which means almost 200 million women of reproductive age on planet Earth suffer from endometriosis. Many women who are suffering from pelvic pain have endometriosis. It's not easy to diagnose because the golden standard for such diagnosis would involve a laparoscopy. That means surgery under anesthesia. A small camera is introduced through a very small incision to the belly button, and we need additional incisions to allow for additional instruments to be used, which will be made in the lower abdomen. So it's a surgery, right? This is the only way we can tell if a woman has endometriosis 100%. We still can't tell if someone has endometriosis clinically. As I mentioned, there are warning signs that endometriosis is there, that you have it. Painful periods, sometimes severe and debilitating. Painful intimacy, painful sex. Pelvic pain in between periods that sometimes radiates to the lower legs and can be quite debilitating. In some women, painful bowel movements during their periods, as well as severe low back pain, not just during periods, but also before and right after. Again, we don't have to do surgery to diagnose endometriosis. A visit where the doctor has the time to spend to talk to you in detail. A visit where you can reveal all of your symptoms in a guided dialogue where the doctor might ask some targeted questions to capture the information. questions that you might have not have thought about. For example, are you having back pain or painful bowel movements during your period? Some women might say, yes, I have severe back pain on my periods. Yes, during my period, going number 2 hurts me. And the doc goes, bling, light bulb. You might have endometriosis. Let's talk about it. So obviously, after the symptom assessment, a very thorough exam and an ultrasound would be very helpful to establish whether there is cervical motion tenderness. That means the physician is going to place 2 fingers in the vagina on each side of the cervix. That's the barrel-shaped structure at the end of the vagina or at the entrance of the uterus. And then the physician will use their fingers to move it around. Obviously, the physician will warn you that this is possibly going to cause some pain because the majority of endometriosis lesions are located on the uterosacral ligaments. You're going to be like, what the heck are those? Well, those are bands of tissue that extend from the back of your cervix, anchoring your cervix to the pelvic wall and the sacrum. Now, those ligaments are crucial and very important. They keep everything up, but they can also become the hotbed for inflammatory endometriosis lesions, which means that every time there's going to be deep penetration during intercourse to the point where the cervix is touched and cause a push-pull effect with a tightening of the uterosacral ligaments that are already inflamed by endometriosis, causing painful sex. Obviously, you can just simply avoid the position that gives you pain. That's an easy fix. It's not a real fix. So let's talk about what conventional medicine does. Well, conventional medicine, without digging too deep into details, approaches endometriosis with medication that drastically decreases estrogen in a woman. Many medications do that, including the birth control pill. And I'll be honest with you, that might help the pelvic pain. It's not going to help the intimacy. Let's discuss why. There are medications like Orilissa or Visan or Visane, I don't know how it's pronounced in Australia, that drastically reduce estrogen. But many women give up and stop taking these medications due to the side effects. So the medications that decrease estrogen, this is how it works. And this is how you don't have the shedding and the bleeding of the tissue anymore. We cut off the estrogen, right? So the tissue is just going to stay dormant. Well, in the long run, the loss of estrogen from these medications will create a loss of lubrication, vaginal dryness, loss of sexual desire. It will create a thinning of the vaginal walls and the skin tissues surrounding the vaginal entrance, possibly lead to a disturbance in the vaginal microbiome, creating a tendency for frequent UTIs or frequent vaginal infections, plus a decreased sensitivity of the tissues down there, which leads to an inability to orgasm, plus all the other symptoms of low estrogen: foggy brain, low mood, irritability, fatigue, achy, stiff joints, etc. Like one of my patients put it very simply, it might feel like there's an 80-year-old woman living in a younger body. Now, I would be remiss to say that these medications do not work. They work. They're very effective. However, the side effects make many women discontinue them early on in the course of the treatment. What is more significant, they are now distrusting of the physician that prescribed them. They're like, this doctor doesn't know jack squat. Gave me these medications. They make me sick. They make me feel bad. They might fail to come back and report the side effects. But in the long run, women with endometriosis really need to stick to the treatment plan, come back to the doctor, discuss what did not work and why. Move on to the next option. We have so many options. And that brings me to the topic of the episode. Let me tell you about what we can do to help endometriosis pain, and specifically painful sex. Well, progesterone in super high doses. Now, those might be too high doses to be tolerated, like 200 to 300 milligrams, can help alleviate some of the symptoms of endometriosis. Progestins, which are synthetic conventional medicine, other class of medications that are also neutering our estrogen, can also be very effective. However, no hormone is more powerful at relieving the significant inflammation driven by estrogen of the endometriosis lesions without taking out your estrogen like testosterone does. So let's talk testosterone. How do we get testosterone into the body? Well, a testosterone cream could help because it will provide an increase in testosterone levels, which can beneficially impact the endometriosis. But by the nature of the bioavailability of the cream, when you apply a cream daily, you only get exposure to the testosterone itself. for about 6 to 10 hours a day, if that. 90% of patients that are tested 8 hours after the cream application already have testosterone levels that are low again and back to the whatever original baseline they had. Testosterone pellet therapy is the optimal way to deliver testosterone when a woman suffers from endometriosis, because we want to allow the consistent and steady state bioavailable testosterone levels that are needed to cure and improve the endometriosis lesions. We want the levels of testosterone to be stable, with some variability, but reliably stable in a 24-hour window, providing steady and consistent levels daily, 7 days a week for about 2.5 to 3 months. So what's an optimal testosterone level to achieve pain relief? Probably somewhere between 100 and 200. You're going to find that in a textbook? No. Are you going to find that in a study? Probably one done by a pellet company that has money enough to invest in this. Remember, there is no money to go into research for women with endometriosis. You're not going to find a lot of studies about this, unless these studies are driven by the pellet companies. Let's talk about a woman's normal testosterone level. It should probably be naturally between 40 and 80 if a woman is young, and likely below 30 if a woman gets past her 40s or mid-40s. Yes, the testosterone levels provided by the pellet therapy are supraphysiologic. That means they do not exist normally in a woman's body. However, 90 to 99% of women who achieve testosterone levels around 150 to 250 do so with minimal to zero side effects. They do not grow a beard. They do not turn into a man. They do not grow a mustache. They do not lose their hair, as I have heard many women ask me. On the contrary, many women run around with testosterone over 200, feeling awesome. Now, is that safe in the long run? Well, there are some studies to say that that's true. However, those studies are not enough to reassure the mainstream practicing physicians and to make this textbook material. It's interesting how physicians who do not practice pellet therapy, who are in charge of the textbooks, are very quick to criticize it. And they have all kinds of bad information to spread to patients or other doctors when they don't really have any intimate or first-hand knowledge of it. Now, I personally believe in the freedom of choice, and I personally believe that the patient should be informed, make her own decision about what type of therapy would be best suited for her. Yes, it is true pellet therapy is expensive. And yes, it is true that pellet therapy is administered by probably 99% of physicians who do not accept insurance. So you're going to have to pay cash out of pocket. My practice aims to be much more than what some patients call a pellet mill. Most women come through, they're not evaluated properly, they get their pellets, they walk away. It's a quick and easy procedure. It leaves both parties happy. One satisfied because they get improvement in their symptoms. The other party, it's immediate cash in their pocket. No need to bill insurance. Easy money. It does not matter to the practice that maybe up to 20% of patients are not balanced correctly, and they choose not to come back or go somewhere else. Because in the long run, the practice remains profitable. Hey, if 80% of the clients return, that's great, right? Well, my practice is a little different. I introduced pellet therapy shortly after establishing the practice, and I started with Sotopel. At the beginning, I billed insurance, and unfortunately, the biller that I employed at the moment knew nothing about billing for pellets. Felt uncomfortable, had no knowledge how to bill for this type of therapy. So when I switched to another biller, I was simply advised, call it a procedure. Don't include an office visit, bill cash. And I did do that for many years. However, in October of 2023, I hired another biller recommended by the BioT company. And amazingly enough, we can get a significant percentage of pellet insertions partially reimbursed by some, not by all insurance companies. And sometimes there's no rhyme or reason. They cover one time, they don't cover another time, especially with Medicare. It's a little like playing the roulette at the casino, right? Now, if you have a valid medical condition that responds to testosterone therapy like endometriosis, it will make sense that your insurance should cover and pay for the pellet therapy. It is cheaper than having surgery. Guys, having surgery will cost your insurance company tens of thousands of dollars. And some women have laparoscopy to ablate endometriosis 2 to 3 times in their lifetimes and eventually end up with a hysterectomy. However, pellet therapy will require maybe 10 years or more before the cost of surgery becomes equivalent to the cost of pellet therapy. So why should we use testosterone for endometriosis? I kind of jumped the gun a little bit and told you about the levels and the pellets. But how does testosterone actually work for endometriosis? Well, we know that testosterone inhibits the growth of human endometrial cells in vitro, right? In a petri dish. That's known fact. We also know that low testosterone levels promote endometriosis. Hello? There are studies that show that testosterone appears to counteract the endometrial proliferative growth induced by estrogen. So now, if we know that these are facts, why is testosterone not recommended for endometriosis like first-line therapy? Again, probably because there are no funds for this type of research, and at this point, the best relief for endometriosis patients is to find a physician that practices testosterone replacement therapy and simply see if it helps them. Now, as a side note, conventional medicine has known that testosterone-like substances are very useful for endometriosis. Danazol is a medication that has been approved by the FDA for the treatment of endometriosis. It is an androgenic synthetic hormone disruptor. Again, let's call it the testosterone wannabe, a testosterone receptor disruptor. It worked really well for endometriosis. However, the side effects were so powerful that the use of danazol has been discontinued. So if I ask a 35-year-old fresh resident, they've never even heard of danazol. We don't even tell people about it. Now, here's the thing. Your feminine body has naturally been equipped with detoxification mechanisms and coping pathways to metabolize bioidentical testosterone. Any similar androgenic testosterone lookalike receptor disruptors, even though they could be very effective in stimulating the receptors and providing the antagonistic opposite effect to that of estrogen, which we want for endometriosis, will carry significant side effects. So I'm going to repeat this one more time. Any androgenic fake synthetic testosterone-like products that are not bioidentical testosterone will have powerful side effects because your body does not know how to get rid of it. Once it sunk its claws into your cells and into your receptors, and again, in order for these androgenic drugs to work, they have to sink into the cell to activate the androgenic receptors, then they sink into the nucleus of the cell. And because these are foreign substances your body has not encountered before, there are no detoxification mechanisms for it. Or if there are, it's because ultimately, eventually, nature finds a way, and our body is very smart, but it could take a long time to do so, which increases the chance and the possibility of side effects, and sometimes these side effects can be permanent. Now, with these products, you can grow a beard, you can grow a mustache, you can have a deeper voice. With these products, you can get acne like there's no tomorrow. So bioidentical testosterone in women is a powerful medical tool. It needs to be talked about more. All OBGYNs should be educated. Now, I'm not sure when that will happen, and women should educate themselves, and hopefully that's what you're doing when you're listening to my podcast, as well as women's partners need to be educated about the benefits of bioidentical testosterone in women who suffer from endometriosis, especially endometriosis pain. So let me address this issue here in today's podcast episode because it somehow seems pertinent and related to what I'm talking about before, about pellets and stuff. So some of the doctors are using their practices purely for the cash revenue opportunity offered by providing pellet therapy rather than meaningfully improving the lives of women. So I want to state here very clearly that testosterone therapy for women is not a tool to be used to improve their partner's life, to improve their partner's sex life. It is a tool to be used to improve the woman's sex life. And that brings me to the fact that some of the doctors that insert pellet therapy are saying weird stuff that turns women off, makes them doubtful, makes them lose faith in the therapy itself. And I'm honestly not making this stuff up. This is information related to me by patients that have been coming to me for care who have been to other doctors and been told, wait for it, this is going to make your husband's life so much better. Who cares? This is a major turnoff. This is such a sexist view because women are not there to please their husbands or partners. They're seeking help for themselves. As it turns out, all of these circumstances are involving male physicians explaining to their female patients the benefits of testosterone therapy from a male's point of view. Now, hey, I'm not saying all males physicians are like this, right? But this is an issue when a cardiology doctor, a rheumatology expert, an ER physician, they open a pellet practice right alongside whatever they're doing to take care of patients because now they can't keep their doors open anymore by taking insurance, so they need to bring a cash element. Now, here's the thing. Inserting testosterone and estrogen pellet carries a responsibility and an expectation that the provider doing it has some understanding of hormones, of sexual and intimacy issues, and some sensitivity training around it, hopefully. And honestly, if you don't have it because nobody has provided it for you, it's easy to get it from different sources. And again, a woman seeking treatment should never be for the benefit of the partner. A woman seeking any kind of treatment should be for her own personal benefit. Women are entitled to seek pleasure and relief from climaxing just as men are. And to kind of close down this chapter, if a couple is imbalanced and the desire for intimacy is stronger on one side than the other, or maybe completely lacking on one side, obviously this would turn into a possibly dysfunctional relationship. The partner who is interested in intimacy might end up seeking their relief somewhere else, having an affair sometimes. Now, most couples are emotionally in tune with each other and the communication is excellent. So they find different ways to address the situation. Sometimes they use a sex therapist, couples therapy, but many times this can be investigated and addressed from a medical standpoint by looking at whether or not there's a hormonal deficiency leading to the situation. So imagine a woman comes in with endometriosis or painful sex. We administer testosterone and we make her life better because the pain's gone. Now she's able to not just have sex, but enjoy it. And on top of all that, she's now full of energy, has great mood, and wants to have more intimacy and be more intimate with her husband. That's a win-win situation, right? So I took a little detour. I'm going to come back to painful sex and continue the discussion by addressing interstitial cystitis. And that will be kind of the little bow on the episode. So what is interstitial cystitis? It is the bladder pain syndrome. So basically the bladder hurts. Now we don't know why it happens, but once it happens, it is a lifelong condition. Now it is very interesting that endometriosis and interstitial cystitis have similar symptoms. It is also interesting that women with endometriosis are 4 times more likely to develop interstitial cystitis, also known as IC. Apparently, estrogen plays a major role in this inflammatory process that occurs in the bladder and is leading to the interstitial cystitis. So we can say that IC, interstitial cystitis, it's an estrogen dominant condition. Now, we do want to address it because if we do not address this inflammatory process that happens within the bladder wall, it will cause a gradual shrinking of the capacity of the bladder. And as the inflammation progresses, the pain becomes more and more the dominant feature. So you might ask, what the heck is the bladder pain got to do with the painful sex? Well, the bladder is located right above the vagina, and the bladder and the top of the vaginal wall are separated by a very fine, delicate tissue that's just barely a few millimeters thick. So if your bladder is painful and you suffer from interstitial cystitis, you will suffer from painful sex. There is no cure for interstitial cystitis, and it can be very difficult to treat. The interstitial cystitis diet is crucial for long-term management. Just Google IC diet. And that's just a lifestyle that eliminates certain foods and drinks that are known to trigger bladder inflammation. Obviously, we can do bladder installations with all kinds of medications. They have been used, but they fail to provide any sort of long-term relief. And they're very uncomfortable when they're being administered. Now, how about pelvic floor therapy? Well, that could help many patients with IC because they experience very tight pelvic floor muscles. So there could be some pain relief with pelvic floor therapy. Pain management with medication. Of course, it's a solution, but it's a Band-Aid. It doesn't address the cause. Now, what about hormones? Well, progesterone is not really talked about, but it can significantly improve IC symptoms. So have your progesterone checked, and some progesterone therapy can definitely help. Now, what about laser? Not laser going through the urethra or lasering the bladder wall internally, but vaginal laser. And why would a vaginal laser work for the bladder? Well, like I said, the bladder is right on top of the vagina, separated by a fine, delicate tissue that's a few millimeters thick. Treating the vaginal wall with Mona Lisa touch or other types of laser, for example, in case of MLT, it will deliver columns of energy into the vaginal epithelium to a depth of about 100 microns, just 0.1 millimeters. Super superficial. However, this is enough to stimulate the body's healing mechanisms and allow blood vessels, collagen, and elastin to improve the quality of the vaginal epithelium. So apparently the back of the bladder, the posterior wall that's resting on the top of the vagina, benefits from the laser treatment. And the healing that is triggered by the laser in the vagina extends to the bladder. So women who receive vaginal laser treatments have significantly improved symptoms and will experience a decrease in frequency and urgency, an improvement of their urinary patterns, and a significant relief from painful sex. Let me end this episode by talking about one more circumstance that affects primarily women who are using birth control. Now, there are young women who are using birth control, and there are older women whose perimenopause is managed by taking birth control. If you didn't know this, please note that most birth control methods work by interfering with your body's ability to produce its own estrogen, as well as its opposite counterpart hormones, testosterone and progesterone. Therefore, many women who seek the certainty and the confidence, and sometimes those two things allow them to avoid an unwanted pregnancy, they might be confronted with the undesired effects of low libido, vaginal dryness, frequent UTIs, frequent vaginal infections, anxiety, depression, leading to the need for antidepressant medications, which again carries a significant impactful risk for someone's sexual wellness because it's well known that antidepressants create, promote, and increase risk of sexual dysfunction. So you want the birth control to want to have sex safely, but on the other hand, you risk all these undesirable side effects. Now, no physician that will recommend the birth control pill is going to sit down with you and take the time to explain the risk of sexual dysfunction and all these possible consequences that will occur like ripples in a pond months to years after using the birth control method. This is just not something that doctors talk about. For most women, this is a risk they're willing to take because the risk of an unintended pregnancy is higher and more bothersome to them. But it is interesting how the tool that is supposed to make our intimacy better and safer when we're younger, to improve it by giving someone the confidence of knowing they're not going to get pregnant by being intimate, it's interesting how this tool could actually take away or significantly impact negatively the ability to enjoy the pleasures of intimacy. So food for thought is I'm not intending this information to be something that will deter you from using birth control. However, specifically the birth control pill, I want to say, from my experience, is the top offender on the list of all birth control methods that does this. Somewhere at the bottom would probably be the non-hormonal IUDs or the low-dose IUDs like Skyla or Kylina. So to sum it up, young women, older women, if you're suffering from painful sex due to vulvodynia, vaginismus, endometriosis, interstitial cystitis, please know that there's such significant hope out there. And just because you haven't found your perfect medical team that can partner with you in your journey to achieve pleasurable sexual wellness, please don't give up. If you're far away and you're not in California, there are other doctors that do exactly what I do. So look for them. But if you're in California, you can click the link at the bottom of this episode from my website and request an appointment. Our team will be happy to guide you and partner with you on your sexual well-being journey. Thank you for trusting me with your time, and thank you for listening to today's episode. If the content I provided wowed you, was helpful and valuable to either you or someone close to you, please do me a favor and leave me a review. I am very open and welcome any kind of feedback as well as suggestions on any content ideas. So please forward those suggestions to Jessica, my patient care coordinator, through our website, herabeautyandwellness.com. And I look forward to our time together next episode.